The State of Influenza project took a look at a 10-year analysis of flu numbers throughout the United States, disaggregated by state, year, and month, and hoped to help healthcare staff and citizens best plan for what they should do during the flu season of the coming year. So the points that we're going to look at are at-risk populations, flu season peaks and outlier states, mortality rates by populations, and recommendations and limitations for this data study. The most at-risk groups, as is to be expected, are going to be 85 plus, which constitutes about 50% of all deaths throughout the United States in a 10-year study. And the next we have 75 to 84, which was about 30% of deaths. And then down to 45 years, we see some deaths happening, but the numbers are really quite a lot lower. Now, just because we have those high numbers of deaths in the 85 plus age group doesn't mean that every state is going to be equally at risk. Even though Texas is the second most populous state in the union, it actually has quite a bit lower population in this age group. So we see that New York and Florida have higher, so that Florida is going to be quite a bit more at risk and should take this into account when they're planning throughout their flu seasons. And every state should also take into account actually what percentage of their population is in these at-risk groups, primarily 75 plus, and try to plan to see what they could do to ease any sort of dangers that could be put on these groups. That could be vaccinations for free at hospitals for 75 plus. It could be awareness campaigns. And we'll talk a little bit more about that in the recommendations slide. So next, we wanted to take a look at which months were going to be the most dangerous. In terms of this 10-year study from 2009 to 2017, we see that January is by far the most dangerous month, although there is some data suggesting that the flu season actually starts as early as November. Although these numbers don't suggest it's getting too bad, we clearly see a rise starting in the early fall months, getting a bit higher around December time. So pretty much we can say there's a general trend that we have double the amount of cases in January versus what we would be planning on seeing in August, but that healthcare providers should take into account that as late as March or April, they're going to see quite a high rise in their cases as compared to those summer months. Now, there are some outliers that don't tend to follow this trend. One of which, as we'd mentioned before, was specifically Florida, and this could be attributed to the fact that they don't have a winter season in as strong of temperatures as a lot of the northern states would have. They also have a much higher amount of people in a very elderly age group. So we can take a look at the most recent year of data, which does show this peak around January, but it's not quite as clear as in the graph above. And states and stakeholders from different hospitals should also take a look at what is happening in their own states in order to understand how the patterns look on a local scale rather than only across the US. Another insight we see is that apart from the size of the population and the dangers that we see in this age group of 85 plus, there were a few states that actually had a much higher mortality rate specifically in this age group. Now, it's impossible from the data sets that we have to be able to attribute that to something specific, whether that be access to healthcare and Medicaid, or whether that be remote living situations or just the general hospital treatment. It's very difficult to say. But we can see that in these two age groups of 85 plus and 75 to 84, we specifically have these states that have a much higher mortality rate. Typically in this very high risk age group of 85 plus, we're going to see below 0.05% mortality rate, whereas these 9 states all have above. Healthcare providers and stakeholders should all take a look deeper into some sort of analysis to understand why this is happening. Perhaps we could look at some best practices catalog in states that actually have very low mortality rates, such as California, despite the very large population. And whether this is attributed to overall population health could also be a factor. So in terms of recommendations, specifically for states with larger at-risk groups like New York and Florida, there should be a lot of extra precautions taken when preparing for flu seasons. Younger citizens should be aware of the dangers. There could be awareness campaigns letting people know that our state has one of the oldest populations in the US per capita, and perhaps there could be subsidized flu shot or vaccination centers for these people, or any sort of radio campaigns letting people know around the holidays that it's actually the most dangerous time for their loved ones, and to take this into account. As a general rule, from November to beginning of April, hospitals should really consider doubling the staff that they would typically have on hand to take care of influenza patients. Although, of course, as mentioned before, there are outliers like California and Florida, and states should always take into special consideration what their statistics and numbers are like. But in general, we're looking at a doubling of staff in the January month. So in terms of these low mortality rates and high mortality rates that we saw on the last slide, there should be more research done into why this is happening. We should also have some of those states with very low mortality rates, creating some sort of best practices catalogs, and we could also perhaps consider not only looking at the deaths in those states, but the deaths of the admitted peoples or the deaths of the peoples diagnosed with the flu. And then we could better understand at what level these high mortality rates are happening. Is it due to low vaccination, or is it due to something that's happening within the hospitals? In general, the limitations of the data set, we didn't have a flu shot ratio for different states disaggregated by age group. So it's very difficult for us to tell who's most likely to get a flu shot, why wouldn't they be getting it, and possibly help us to plan as to how we could encourage people of different age groups to get the shots during this flu season period. As mentioned before, there's no access to the number of cases per state. We have the number of deaths, but we can't actually see what the mortality rate is amongst positive cases. We can only disaggregate it by the entire population. So this disaggregation would help us better plan as to whether or not we should be focusing more on flu shots and vaccinations, or more on the level of care that people are receiving once they're actually within the hospitals. And another thing that we didn't have in this data set specifically was any information about the COVID pandemic. Of course, we're working with a data set from 2009 to 2017, so it was just a few years before the pandemic actually started affecting the healthcare industry. And that's going to have an effect on how many influenza patients we might be seeing, or the severity of cases that are taking place as well. And finding any sort of data sets with disaggregations on those effects on the influenza season would be very, very helpful for hospital planning. Thank you everybody for listening.